This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
He is a 65-year-old gentleman who has been posted for cataract surgery. He has this non-dilating pupil, secondary to pseudoexfoliation. He has an immature cataract. The nucleus would be around grade 2 to grade 3. But what's very evident is this gap between the iris and the lens, and we can clearly see the shadow. Now, this is an ominous sign. It can suggest presence of a zonular weakness. Well, that is to be expected in this eye because this is pseudoexfoliation and with a rigid pupil, and more likely that the zonules are going to be weak. So let's start the case. The priority is always going to be to deal with the situation in a step-by-step manner. The first, the pupil is dealt with. Then we are going to have a decent rhexis and have a good hydrodissection, and then the nucleus management is going to be very simple. So when I'm trying to stain the capsule, I'm mindful to use as little dye as possible because these are the eyes where the dye can escape beyond the zonules into the Berger space and then cause the loss of red reflex in the later stages. So apart from this, it also has a risk of causing fluid misdirection. So in these eyes with suspected generalized zonular weakness, it's better to be mindful and use as little fluid as possible. So before proceeding, I would like to stretch the pupil using Y-hook because pre-stretched pupil is going to be much more amenable to be stretched easily by the B-HEX pupil expansion device, which I plan to use in this case. Now this is because this pupil is a rigid pupil, and because the B-HEX device is slightly thinner, it may not have the tensile strength to force it open on its own. So it's better to have it pre-stretched a little bit. This helps us to maneuver the B-HEX ring much more easily. So here I am doing the stretching in 4 diagonally opposite directions. Care is taken not to reach up to the limbus. I am reaching maybe 80 to 90% of the limbus just to ensure that the pupil is really well stretched. Excessive stretching can give rise to a large sphincteritis, which might not be very aesthetically pleasing to look at later. And also we need to be mindful that when we stretch the pupil, it also makes the iris a little bit floppy. So this floppiness can be very well be minimized or controlled by using the B-HEX device, which is what I'm going to use now. The first 2 pair of notches are introduced and engaging the pupil, followed by the next 2 pair of notches. The hands are switched and the last pair of notches are engaged into the pupil, and we have a decent opening in the pupillary size. The chamber is pressurized by viscoelastic, and this is the moment which is going to reveal the status of the zonular health. I'm touching the capsule and we can see the folds radiating from it, suggesting significant zonular weakness. Well, that was anticipated. The flap is raised and I begin tearing. So again, I need to be mindful that whenever we have zonular weakness, the rhexis tends to be smaller than what we actually intended it to be, simply because of the lack of countertraction by the zonules. So I need to be mindful that I have a reasonably sized rhexis, and always I prefer to use the forceps in eyes which have zonular laxity. It is much more easier to tear and well controlled. As I keep repeating myself, the most critical step after rhexis is always hydrodissection in such eyes. A little amount of fluid is injected under the capsular margin and I nudge the nucleus down and away a little bit. A couple of nudges reveals that the hydrodissection has been effective and the nucleus along with the cortical mass is free from its attachment to the capsular bag. The overlying cortex and the epinucleus is aspirated. Now is the time to perform the direct chop. I'm planning a vertical chop in this patient. Tip goes in, buries into the substance of the nucleus, and then the vertical chopper goes down and then laterally. The central endonucleus is not cracked. I have a crack which is more peripheral. Nevertheless, the nucleus is rotated and I continue to perform the vertical chop, dividing the nucleus into multiple smaller fragments. As I always keep repeating, the chopping is usually done in a longitudinal mode. My Phaco is set it just longitudinal mode. I'm not using the torsional. Now is the time to do the cotton removal. Each of these fragments is pulled out of the bag and then emulsified in a controlled manner. Again, as we can notice, the settings are again changed to torsional when you're doing cotton removal. So while cotton removal, we want the cutting ability of the tip to be at its best, and torsional is the one which does the job the most effectively. And that's the reason why I prefer to use torsional mode during cotton removal. The epinucleus just floats up and it's gently burped out of the eye. I'm using the irrigation handpiece to retract so that I can visualize where is the cortex and where is my aspiration probe, and gently I engage the cortex and then aspirate it. We need to remind ourselves that cortex aspiration can be tricky in these eyes with pseudoexfoliation and weak zonules. Many times we end up causing zonular dehiscence because the anticapsule has a tendency to get caught in the aspiration probe or the equator of the bag, and which can result in zonular dehiscence. So being very slow and very observant helps us to minimize this complication. But nevertheless, during cortex aspiration, again, it was very evident the zonules are not great. Time to insert the CTR. Bag is inflated with the OVD and then the CTR is gently threaded into the bag. The planned single-piece hydrophobic lens is implanted into the capsular bag. So the IOL seems to be in the bag. It's always better to check whether both the haptics are inside the bag, especially in eyes with small pupils. So I'm using my Synscube just to retract the pupil and visualize that the haptics is well and truly within the bag. I just ensure that I'm repeating it the other haptic, and I'm confirmed and I'm convinced that both the haptics are in the bag. With the OVD still inside, I'm disengaging the notches of the B-HEX ring so that it can be removed. Carefully and surely the B-HEX ring comes out. Now is the time to remove all the OVD which is there in front and behind the lens. The lens is gently tipped up and the irrigation handpiece is introduced under the optic. All the OVD which is there is gently washed off. I'm having these small tissue threads which are coming from the sphincter, which has a pseudoexfoliation material as well. It's floating around in the center, and I'm concerned that it might cause any visual disturbance. So I'm just going in with my micro forceps and trying to peel off these small threads of tissue. That's it, time to close. Side port hydration is done, the main incision is hydrated as well, and that's it, the case is done. So that was it. Thank you for watching and hope you found this helpful.